Welcome to the University of California, San Francisco Sports Medicine Podcast, featuring Dr. Nirav, Pandya, Dr. Brian Feeley, and Dr. Drew Lansdowne, discussing hot topics in sports medicine and society. We hope you enjoy our podcast and look forward to hearing from you.
All right, welcome everyone to our UCSF Sports Medicine Podcast, 6 to 8 weeks with myself, Dr. Nirav Pandya, and Dr. Brian Feeley. We're not quite sure where Drew is today. Who knows? Network, junior partner. Obviously huge news this week from the 49ers. Trey Lance broke his ankle. And obviously when a major professional athlete has a fracture, lots of questions come up. Everyone becomes an expert on fractures, broken bones, ligaments, what it means in terms of return to play. So we thought it'd be a great time to kind of break down broken bones. What does that mean? And kind of the way we think about it, would you rather have X or Y? I think it's a great way to kind of break down how you would approach fractures. So kind of first question for you, Brian, before we kind of jump into the would you rather, is it better to break something or fracture it?
I really like how you said break down and then talk about breaking bones. A nice wordplay to start with. It's the same. So patients will say, well, I didn't break it. I fractured it. It's a bigger deal. It just means the same thing. We'll get to that for other terminology as well. I'm going to ask you the first question. Do you think it was a good idea that they kept Garoppolo? And is it a conspiracy that Kyle Shanahan really just wanted the handsomest man in football to be starting for him?
I think, the Jimmy G is a good looking guy, and that's really all they want. Like if you go up to the press conference, if you win, you lose. If Jimmy G is up there, everyone's happy. So I think it all works out. But yes, the very interesting 49ers quarterback situation. We don't like you, Jimmy. Go away, Jimmy. Come back, Jimmy. Now you're going to win us a Super Bowl. So it's all very interesting.
Yeah. I saw that the offensive line was ranked in the top 10 somehow after all summer being told that our offensive line is the worst part of the team. So who knows? So I love the game Would You Rather because it keeps kids interested in long car rides. But I also think it's interesting when you think about different injuries that you would or would not want to have. So I'm going to ask you the first question since I've already torn my ACL, so I know the answer. Would you rather break a bone or tear your ACL?
So in general, I would rather break a bone as long as that bone wasn't broken near my joint. Part of the reason is that we know bone heals pretty predictably. Like as long as you get bones lined up properly, whether you're a young patient that's in a cast, you get plates and screws or something else to fix it. Bone healing is pretty predictable. And as long as you're not a smoker, you're not diabetic, you're not overweight, have risk factors, we know that bone will heal. And that once bone heals, for the most part, it's back to normal. Like I think you have a very good propensity to have that bone go back to function, and your muscles and tendons and ligaments are usually fine. I think the reason why I wouldn't want to tear my ACL is that we know after ACL surgery, even though we've gotten really good at it, there's a chance you could re-injure that. And I think the chance of re-tearing your ACL is much higher than re-breaking the same bone. And the rehab's a lot harder. Like once your bone heals, you go back and you can pretty much train. There's so many more factors in terms of getting mobility back, getting, kind of your sense of where your knee is in space. It's just a harder rehab. So I always say bone, it's better to break bone. Soft tissue injuries are just so much less predictable in terms of how they heal. And Brian, you can obviously talk about this with your research, like why is soft tissue, why doesn't it heal as good as bone does? Like what's the deal with that?
Yeah, I don't know. That's why we have research on it. I think you bring up a bunch of good points. So when we say bone heals, it typically takes for a younger person, so under the age of 30, about 6 to 8 weeks until you see enough new bone that you can start thinking of doing at least non-contact things. So for me, I see a lot of clavicle fractures and I say, well, if you're going to get this fixed or you heal quickly, you can be back to play football in the same season. For ligament injury, so for an ACL, we talk about this to be a 9 to 12 month recovery. And that's really because we're not just putting two things close together and getting them to line up. We're giving you a brand new ACL for the most part. And that means you not only need to heal from the surgery, which takes a while, your muscle atrophies from the surgery, but then you need to essentially create a new ligament down that reconstructed ligament. You need more cells, you need a blood supply, you need a nerve supply. So that's going to be a lot longer. So why do you think it's going to take a full year for a Trey Lance to get back?
But yeah, that's a great question. Everyone's like, well, bone heals in 6 to 8 weeks. Well, I think there are a couple different things for that. Number one is that particularly with his kind of injury, it was reported. I mean, there's bone and there was a ligament injury as well too. So that kind of makes things a little bit more complicated. But more importantly, it's just not when your bone heals, right? So yeah, you could lay in bed and 6 weeks later your bone's totally fine, it's all strong, but then you have to basically gain your function back, get your mobility back, et cetera. So even though it's better probably in the long term in terms of that bone healing and not worrying about re-injury and all those other things, there's functional healing as well too. So your structure heals, but you have to get that ankle back to basically playing football, and then there's also the emotional kind of mental component of it as well too. Like, how confident are you going to be having 300-pound linemen fall at your leg, have that impact as well too. So it can sometimes take that full year to get back, not necessarily because the bone's not healed, but because it's a functional part of things. So I think it's important for patients to know that even though, we'll get an x-ray and says, oh, your clavicle is healed now, or your ankle is healed, or your finger fracture is healed, that doesn't mean you jump right into playing high level sporting activity. You pretty much have been doing nothing. So sometimes a longer part of rehab is the not just when the bone heals, but it's getting that strength and mobility back, which is predictable. It just takes a long period of time.
Yeah, I think that's a great point. I think the important thing to consider too is anchoring, especially for somebody like Trey Lance. If you tell everybody he's coming back in 12 weeks and then it takes 14 to 16 weeks, people are going to panic. But if you say he's out for the year, we make the playoffs, Jimmy G gets injured and Trey Lance is available, that's a totally different story and it's a totally different narrative. So I think it's always the right thing to do to back off, be slow in when people come back, and then move the timetable up rather than the other way around. And it's really important when we set expectations for patients. You may be able to get back a little bit faster from some sort of injury, but realistically, let's talk about what the middle of the bell curve looks like. Aim for that. And if everything goes well, fantastic. If not, if there's a little bit of a setback, it's not that big of a deal.
Yeah.
Now I'm going to ask you the second question, or the second would you rather. Yeah. And we know that Chet Holmgren injured himself on a non-contact injury and had a Liz Frank, we'll just say fracture dislocation, but an injury in his foot. Would you rather break a bone in your hand like Dak Prescott, or break a bone in your foot like Chet Holmgren?
I would rather break a bone in my hand, because I think, obviously that would mean time out of the operating room. But I think in general, when you look at, finger fractures, because you're not weight bearing on it, right? So, in terms of day-to-day function, putting aside what we do in terms of surgeons or if we're upper extremity athletes, you basically, like with finger fractures, because they're not stressed as much, as long as you don't get stiff, it's pretty predictable for them to heal. And yes, you could have a little bit of discomfort here and there, but it's not going to impact me on my day-to-day life. Foot injuries are so much more complicated because number one, the blood supply in general to things around the foot are a little bit less. And number two, it's harder not to be able to walk around. Like, I can live most of my daily life with having a finger fracture, but in the foot, it can be painful. It's going to be hard to run and jump afterward just because you're stressing that area. People don't typically stress their fingers as much. So for me, I would much rather break something in my hand and know that there'll be a little bit of time off, and rather than breaking my foot, which can suddenly be like an 8 to 12 month recovery process because the foot has so much more stress across it than my fingers.
Yeah, we won't tell the hand surgeons that we know that we actually think a foot is a more complicated hand with an arch, but I totally agree. I think a couple things that come in mind. First of all, with a hand injury, although it can be debilitating, there is a chance that it's your non-dominant hand. So I'll take a 50-50 chance that it's my right arm. I don't use my right hand too much in surgery, so I could probably keep operating just with one hand, but that's just because I'm also more talented than you in the OR. I think the other thing is non-weight bearing has that whole host of other things that we know about. When you have an injury of the foot, we make you non-weight bearing for the most part, meaning we're going to put you in a cast or a boot and then tell you don't put any weight on it. That means your muscle is going to atrophy. We know from a lot of really good data that as soon as you go non-weight bearing, within 72 hours, you've already started to lose muscle mass. So if you're going to be Chet Holmgren, you're going to have surgery, you're going to be off that foot for probably 8 to 10 weeks, and then have to go back and not only get the foot to be able to maintain stress, but then be able to rebuild muscle. That's why those injuries take so much longer. What do you get when you rest muscle for a long time?
Oh, that's a dad joke. Trophy.
Right? Yeah, thank you, Twitter. So
Yeah.
that's why we're going to have to do some editing for this one. Okay. So we touched on this a little bit before. Would you rather have an open fracture or a compound fracture?
That is an excellent question because they're actually the same thing, and I would want neither. And it's interesting, and it would be interesting to always look back and say, where did this term compound fracture come from? Because it's
Right?
what's commonly used. Yeah, it's in orthopedics. The classification we use is called an open fracture, and the reason we call it an open fracture is that the bone comes out through the skin. And when everyone was talking about the Trey Lance injury, everyone was like, "Oh, luckily it's not a compound or it's an open fracture, it's going to be fine." And then I saw some comments on social media. They're like, it's not a big deal if you have an open fracture, it just means the skin has to heal. And I'm like, no, 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 no. This is, having the bone come out of the skin is a big deal for two reasons. One is the obvious reason is that anytime bone comes out, it can bring bacteria in. Your skin is your greatest protector of infection, keeping the outside world out. So, especially with a football player, if the bone comes out through the skin, it can get turf, it can draw dirt, bacteria. It's just a big setup for bad things to happen. And we can talk a little bit about Alex Smith, but in general, then it makes things more complicated because you're trying to get rid of infection and then also fix the bone as well too. And anytime there's an infection, it's bad, and it also can prevent bone healing. So that's number one. Number two is that if you have an open injury, it does typically mean that there's more energy going across the fracture as well too. So if you take the same ankle fracture, one's open, one's not. The one that's open probably has more associated damage to muscles, tendons, and ligaments as well too. So even that alone, putting the infection aside, it probably means if I had an open fracture, I'm going to be dealing with a lot longer rehab and have a lot poorer outcome than individuals who didn't have that. But the good news is, and we can talk a little bit about Alex Smith, is that if you do look at the data for most open fractures in NFL players, they get back to play and they actually do relatively well. And a lot of that has to do with the fact that we get these players antibiotics pretty quickly, which is the most important thing. We clean them out very rapidly and get their bones stabilized. But you can have cases, and a little bit like Alex Smith, where an infection does happen, and then you could subsequently then have a poor outcome.
Yeah, I think it's really interesting when we look at NFL players and how they do, but I think it really tracks with what we see clinically. When we look at a variety of different patients that have had open fractures in the NFL, they're pretty rare, thankfully, but we see the same thing we see in patients. Most do well. Some are going to have a near catastrophic outcome and take 2 years to get back, but they can still get back. What we don't really talk about for the NFL, and I think is important to mention for patients, is that these can be limb-threatening injuries. And an open fracture is something that we treat emergently because we need to wash it out. That severity of the soft tissue injury, even if you see a 1 centimeter poke hole in the bone, that usually, or poke hole through the skin, usually means that the surrounding 5 centimeters of tissue was severely injured. So I do think it's a big difference for Trey Lance that it wasn't an open injury, even with the best of circumstances like Alex Smith had, these can be devastating injuries that are treatable. Having it be a closed injury, even though it's going to be a slow recovery, is really important. All right.
Yeah, oh, sorry. I'll add one thing on as well too. And I think a lot of people in general, when they think about these little poke holes as well too, one of the things we see in younger patients is that their skin is so flexible. So I've had patients with like a little tiny poke hole, their skin expands. Next thing you know, there's like grass, pieces of clothing in there. So even though, I always say, like, if someone's broken a bone and you've got a little poke hole or something like that, it's always good to check to make sure there's anything in there, because it's amazing what you'll see in there. And I show Brian, when you were doing a lot of trauma as well too, you're like, wow, this bone is just like looks dirty. Like, how did this happen from just such a small hole? So I think it really does emphasize how getting rid of the infections, the most important thing, and then everything else will follow after that. Yeah.
So my last question for you, would you rather, when we talk about being fixed for a fracture, would you rather have a plate and screws? And what is a plate and screw? Like, is it a dinner plate? Because honestly, it's not a term that actually makes sense. Or would you have a rod shoved down the middle of your bone?
Yeah. So I would probably want a rod. And part of the reason is that when we think about these different devices to fix bone, and the bone is actually kind of like hollow in the middle, like there is a space in there. It's called the canal. There are kind of two ways you can fix a bone. And one of the reasons why you want to fix bones is, particularly in adults, is that you need something to make the bone stable so that it's more likely to heal. And that you also want the bone ends to be closer together, because the closer together they are, if they're lining up, they're more likely to heal, and they're going to heal in the right position. So there are two ways you can do that. One is you put a rod down the middle of the bone, and that basically is almost like acting like an internal brace almost. And that allows the bone to heal and be stable. The good thing with rods, is that you can actually, they're called load sharing devices. So basically you can you're not worried about this plate or screws. We'll talk about what that is, kind of like having a high stress area and then the bone above and below it has issues. A rod, you can usually start walking on it. It's a little bit better for your tissues because you're not having to make a big incision. You can do it through very small incisions. So in general, I would like a rod because it allows me to kind of get back to activity better, less issues with tissue, and less likely to need another surgery. What a plate and screw actually is it's almost like woodworking. So if you have like a bracket or something you need to put on the outside that basically holds the bone in place, and you put screws through that piece of metal to basically stabilize the bone. And sometimes you can't put a rod in because you don't have room for it or the bone's too broken for it. So then you have to put this large piece of metal on the side of the bone and put screws through it to hold it in place. That's very good, very strong because it's basically holding that area of bone together. But you can imagine then you have stress above and below that plate, which can be problematic. And sometimes you need to get it taken out. And sometimes the bone necessarily doesn't predictably heal, and you need a bigger incision to put it in. So for me, I'd rather go rod rather than plates and screws.
Yes and no. I'm going to disagree with you a little bit. I think it depends on the fracture. So when we talk about doing the right treatment for the right patient, I think most of the time when you break a femur or a tibia, so something in your leg or sometimes ones in your arm, it's totally reasonable to get a rod. But for a lot of fractures, like around your clavicle, a rod doesn't work very well. And in fact, can lead to things called pin migration, where that pin can go pretty much anywhere in your chest. So I think it's important to have the right surgery for the right patient. And certainly where I've seen rods fail are right around the joint. So when you have a fracture that's really, really close to the joint, when there's bigger deforming forces, sometimes you need a plate to get everything lined up. So I'm going to say I would rather have the surgeon know the right surgery for me to make sure I get the right fixation. But for you, if you come in with a broken bone, I'll just put a rod down anything and hope for the best.
Exactly right. And the question the patients always have is, are we really using drills? Like, are these like Home Depot drills to put this stuff in? Like, how are we getting this stuff in?
Yeah, we use a drill. So bottom line is bone is a lot like a piece of metal, or sorry, a piece of wood with a soft spongy core on the inside. So we use a drill, and the basic principle when we do a plate, which is going to have the screw holes in it, is we drill a smaller hole, and then the screw will get some purchase on the bone as well, and that allows it to be a solid fixation. So for instance, most of the screws we use for adults are 3.5 millimeters in diameter. So we'll use a 2.5 millimeter drill. If you look in your drill collection, that's not small. That is a significant size drill that we put in, but that's what you need to maintain rigid forces across a healing fracture.
Yeah. And I think the other question people ask me before we finish up here is, does that metal or rod ever need to get taken out? And, the way I like to say it is, if it bothers you, obviously, but are there other reasons why you would need to take it out, or can you leave them in forever, Brian?
Yeah, you can certainly leave them in forever. Almost all the metals these days we use are inert, meaning they do not react with your body. Some patients, especially for more superficial injuries, so you can think about the outside of your ankle way down by that bone. If you have a plate that's pretty superficial and you're skinny and you're wearing high tops for basketball, for instance, it may irritate the skin a little bit, or it may make you feel a little bit worse. Same thing for people that do a lot of backpacking and clavicle fractures. About 15% of people are going to want that hardware out. Do you need it out? Absolutely not. But it's not a rush to take it out. So usually what I tell my patients, especially for clavicle fractures, which is the most common thing I plate, is at 3 months, it's going to be bothering you. It feels a little bit different. The muscle is smaller. At 6 months, may or may not be bothering you, but we can think about when to take it out, closer to 9 months to a year, or any time thereafter. There's no rush to taking it out. And oftentimes patients who think I might want it out at 6 months, by 9 months, they feel totally fine. Don't want to go through even a small additional rehab at that point.
Exactly right. Well, we could have hours and hours talking about fractures, but we are sports surgeons, so we'll leave that to the trauma guys and girls. So once again, thanks to everyone to listen to our podcast, 6 to 8 weeks, hoping for a speedy recovery for Trey Lance, and we look forward to have you on for our next episode. Thanks.